Are you a curious patient, a medical student, or a medical professional looking for a refresher understanding of a full hemogram test? It is one of the routinely ordered blood tests in clinical practice, also called a complete blood count, total blood count, or full blood count. The test provides significant information on the quality and quantity of blood components, helping in the diagnosis, management, and monitoring of a wide range of medical conditions. The full hemogram is divided into three main segments, namely the white blood cell section, the red blood cell section, and the platelet section. The right blood cell section assesses the immune and inflammatory response of the patient. The red blood cell section explains the perfusion status of the patient based on the presentation and the count of the red blood cell components. The last segment is the platelet section, which highlights the coagulation aspects of the patient's blood as presented by the platelet count. This presentation provides a comprehensive insight that helps you grasp the clinical implications behind each parameter of a complete blood count. I would definitely be glad if you followed us on our social media platforms and subscribe to this channel now to help us create more contents like this. Let's get into it after the short introduction. So let's start with the white blood cell section, and I'll be calling it the leukogram in this presentation. The total white blood cell count usually ranges between 4,000 to 11,000 cells per microliter of blood, or 4 million to 11 million cells per liter of blood. There are two main types of white blood cells, and that is from basic immunology. We know the two blood cells are granulocytes and agranulocytes. The main difference between the two is because granulocytes have granules from their name. They have granules in their cytoplasm, while agranulocytes do not have granules in their cytoplasm. The other difference is granulocytes have nucleus that are multi-lobed. They have multiple lobes in their nucleus, while agranulocytes have single-lobed nucleus, just those two. So granulocytes are usually 3 in number, and we can use the mnemonic BEN for them: B for basophils, E for eosinophils, and N for neutrophils. Out of these 3, neutrophils are the majority, and they usually occupy around 40 to 70% of not only the granulocyte count but the total white blood cell count. So if the white blood cells are elevated, most likely you first of all look if the neutrophilic value is normal. Okay, agranulocytes on the other hand lack granules, like we have said, and they include the lymphocytes and the monocytes. So granulocytes are 3: BEN, basophils, eosinophils, and neutrophils. Agranulocytes are 2, that is lymphocytes and monocytes. So let's start with the granulocytes. So I'll start with the largest of them, that is, in terms of count, the neutrophils. So they form the majority of the white blood cells, that is usually at 40 to 70% of the total count, and we have said that neutrophils are also the first responders to the site of infection. They're the ones that are usually involved in killing the disease-causing microorganisms through the process called phagocytosis. If elevated, the condition is called neutrophilia, that is the high neutrophil count. So if low, then it's called neutropenia. So neutrophilia indicates bacterial infections, that if you find a full hemogram with a high neutrophil count, then that shows there is a bacterial or pyogenic infection or an acute inflammatory response that is occurring following an injury or a catastrophic event. If the count is low, that is neutropenia, then it's also an indication of a bacterial infection, and especially for the low count, it means that the infection has been there for quite some time and has not been able to resolve. When an infection first comes into your system, the white blood cells, neutrophils, are elevated to try and fight the infection. If they're not able to fight, then the infection or the disease-causing microorganism fights them, and they're going to go down in number because they are killed in that process. And if this happens over a long period of time, then the neutrophils will be killed and they will be lower in number, and that is what we call neutropenia. So neutropenia still is an indication of bacterial infections, but of course as a result of a long-term inflammatory action. But neutrophilia is an indication of a bacterial infection as a result of an immediate action. So let me ask you, from these two perceptions, which one between neutrophilia and neutropenia is an emergency? Which one is more dangerous to the patient? You'll tell me that in the comment section. The other part of granulocyte, the other type of granulocytes are the eosinophils. They are always elevated in allergic and parasitic infections. Just understand that if eosinophils are high in number, then it means there is some allergic or parasitic infections that are involved, and we need to check that. Basophils, on the other hand, are always elevated in allergic reactions, especially those that involve histamine production, hypersensitivity, chronic inflammation, infection, and sometimes hypothyroidism. You'll always see them elevated in immediate allergic reactions like in bee stings and all that. Basophils and eosinophils will be very much elevated. The other types of white blood cells, of course, we say that are granulocytes, and those are lymphocytes and monocytes. So let's start with the lymphocytes. There are of three types. There is usually the B lymphocytes, the T lymphocytes, and the natural killer cells. The B lymphocytes are involved in production of antibodies, while the T lymphocytes are those that regulate immune processes and kill abnormal and infected cells. The natural killer cells, on the other hand, they attack viruses and cancerous cells in the body. When we have an elevated lymphocyte count, it's called lymphocytosis. If it's low, it's called lymphopenia. Lymphocytosis indicates a viral infection like whooping cough, all those viral infections, especially those of the respiratory tract. We'll always see them marked with lymphocytosis. And then there is also an element of malignancies that could be captured in lymphocytosis, and smoking could also lead to an increased lymphocyte count. So lymphocytopenia, on the other hand, indicates viral infections still, and then autoimmune diseases, and importantly, HIV/AIDS are usually marked with low lymphocyte count. So this is an early indication of HIV. You could always look at it and screen further. It also indicates malignancies and old age. Of course, old age is as a result of the aging process. Usually most cells die because people are aging. And then we have immunosuppressive medications could also lead to lymphocytopenia. Bone marrow diseases and renal failure, of course, could also lead to this. Monocytes usually turn into macrophages and dendritic cells, and they are therefore involved in peripheral inflammatory processes. Monocytes are therefore usually elevated in bacterial infections, steroid use, and situations where there are autoimmune disorders. We'll look at examples later, but for now let's go straight to the red blood cell section. I'll call it the erythrogram for the purposes of this presentation. The red blood cell count is the total number of red blood cells in circulation. A low count is usually called anemia, and a high count leads to what we call polycythemia. So the total count is usually of a range between 4.5 to 6 million cells per cubic liter of blood. So in the red blood cells, there is something we call hemoglobin, which is the most important thing we always rush to see in a full hemogram. It is the ion-containing element of blood and helps in oxygen transport throughout the body. So the normal range for hemoglobin varies between the different genders. For men, it's between 13.5 to 17.5, while to women, it is around 12 to 15.5. So low HB is anemia, of course, while a high HB count is what we call polycythemia. Anemia can be associated with many factors like blood loss, we know that, hemolytic diseases, hemoglobinopathies, bone marrow suppression, those are tumors of the bone marrow, nutritional deficiencies, and many other causes. While polycythemia is always related to factors like dehydration. There could be dehydration, meaning the plasma count or the liquid part of blood is really low. That means that HB, or the red blood cell part of blood, will be more, and that will lead to a high HB count. It could also be in situations like in hypoxia, for example, in COPD. If the body is deprived of oxygen, the system tries to regulate, so it produces more HB to try and cover for the insufficiency in oxygen, and that is why hypoxia in situations like COPD or those who like smoking may end up with high HB counts. And also in polycythemia vera. Polycythemia vera is a tumor, of course, of the bone marrow, and it usually leads to an increase in production of the red blood cells. Erythropoietin producing tumors are also factors that could lead to a high HB count. In the kidneys there's a protein which is called erythropoietin, and this protein is usually involved in production of red blood cells from the bone marrow. So erythropoietin activates that production from the bone marrow. So if we have those tumors, it means they will they will enhance overproduction of this hormone, and this will increase the rate of production, and as a result we could have a high HB count. The other part of the red blood cells is the hematocrit. It is the total number of red blood cells circulating in blood. That means out of the whole blood, that part that is made up of the red blood cells is what we call the hematocrit. The normal range is usually between 40 to 55% in men and 35 to 45% in women. Again, a higher count is experienced in polycythemia, and then a lower count we see in conditions such as anemia. Then MCV, one of the important segments of this presentation, we are now getting there. MCV is the average size of the red blood cells circulating in blood. It's more of the size of the red blood cells. If the size is low, we call this microcytic anemia. If the size is high, we call it macrocytic anemia. So the normal range is between 80 to 100. If it's beyond 100, we think of macrocytic anemia. If it's below 100, we think of microcytic anemia. So causes of microcytic anemia, we can remember that by mnemonic tails. T for thalassemia, and when you say thalassemia, you also remember other hemoglobinopathies. They also cause microcytic anemia. So T for thalassemia, A for anemia of chronic illness. So chronic illnesses can also lead to anemia. You know, those chronic illnesses that cause bleeding, such as cancer. Those chronic illnesses like HIV and AIDS can lead to what we call ITP, and that can lead to anemia. ITP is immune thrombocytopenic purpura. When you have that thrombocytopenic purpura, we'll see that when we talk about platelets, it can lead to a lot of bleeding, and that can also lead to a low MCV. And then I for iron deficiency, and then L for lead poisoning, and of course S for sideroblastic anemia. So you can go and read about anemia, but the most important part here is that a low MCV count leads to microcytic anemia, and the causes I've told you. A higher count leads to macrocytic anemia. So macrocytic anemia, of course, is caused by liver diseases and lack of vitamin B12 or folate. We'll talk more about this when we handle anemia as a topic. So you can go and refresh your memories of anemia, but for this you have to understand a higher count is macrocytic, a lower count is microcytic anemia. The other part I want to look at in the red blood cell is the mean corpuscular hemoglobin, what we call MCH. It is the average amount of hemoglobin in red blood cells circulating in blood. Mean corpuscular hemoglobin addresses the proportion of hemoglobin in blood. The normal levels are usually between 27 to 32. A higher count is what we see in hyperchromic anemias, while a lower count is hypochromic anemia, of course. A normal count is normochromic. So MCV and MCH values are used to classify macrocytic and microcytic anemias. We could have a low MCV, a high MCH. Then that means we have a microcytic hyperchromic anemia. If it is a high MCV, a low MCH, then we have macrocytic hypochromic anemia. If we have all of them at normal ranges, then we have normocytic normochromic anemias. All that derangement are used to classify those anemias as either hyperchromic, normochromic, or hypochromic. So you need to understand when the HB count is low, you have to look at the MCH and the MCV and try to look which picture of anemia is brought out by that. And then the other part, of course, is the mean corpuscular hemoglobin, which is a red blood cell index that indicates the concentration of hemoglobin in red blood cells. So this is just MCH addressed as a percentage of the entire hematocrit. So it is calculated from MCH. So MCH divided, of course, by hematocrit times 100. That percentage is what we call the mean corpuscular hemoglobin concentration. A higher concentration, of course, indicates autoimmune hemolysis and conditions like spherocytosis. Spherocytosis is those round red blood cells instead of the usual biconcave disc shaped. We have round blood cells. So that is one of the disorders of the red blood cells. It's called spherocytosis. We'll look at it when we discuss that as a topic. And then a lower count, of course, is usually signaled in iron deficiency anemia. The second last part I want us to look at, which is very important, is the red cell distribution width. So the red cell distribution width measures the average variation in sizes of red blood cells. The sizes should not vary too much. Then the range is usually around 11.5 to 14.5. If we have a higher variation in size, this is usually called anisocytosis. It means that there is a very significant gap between macrocytic cells and microcytic cells. And these presentations are common in those patients with absorption or malabsorption disorders. It means that in the gut, there is no proper absorption. So we are not having proper absorption of iron, and we are also not having proper absorption of specific components of iron like vitamin B12. So we have very wide variations in the sizes of the blood cells that are available. We have both macrocytic and microcytic anemia. In this situation, most of the time you may see no change in the MCV, but you'll always notice the wider variations in the RCDW, that is the red cell distribution width. So example of these diseases are like in celiac disease, and sometimes for surgical traumas. After surgery, the absorptions are usually affected, and you could see this RCDW expand. That means that this patient has absorption disorders, and the anemia could be because of malabsorption. Okay, I hope we understand that. The other part is the reticulocyte count, and this is the last part I want us to address in the red blood cell count. The reticulocyte count is the amount of immature red blood cells. Those are reticulocytes. Immature red blood cells are called reticulocytes, and they're usually released from the bone marrow into the peripheral blood. The reason they're always released is a feedback. If there's a signal that there's a need for a compensatory action, especially during situations where blood has been lost in peripheral circulation, or where there's something like hemolysis, then the reticulocyte count will increase. The reticulocytes will be released to go and try to compensate for that deficit. So a higher reticulocyte count indicates that feedback. There is a process that is taking place to compensate for some kind of cells that are being lost due to either blood loss from the peripheral circulation or hemolysis or any other thing that is happening. A low count indicates bone marrow disorders, of course, that is in conditions like aplastic anemia, malignancies, and those disorders associated with the bone marrow. Wow, so let's stretch a bit, and as you stretch, breathe in, at least drink some water. If you have a soda, you can take a sip. And as you do that, please remember to subscribe to this channel to support our foundation, our organization, Medifield Healthcare and Research Foundation. Remember to subscribe to our social media pages, our Facebook page, TikTok page, Twitter, Instagram. If you're there, you can follow us there to ensure that you support this kind of medical educational content that we intend to consistently have with you. Let's get into the last part of the full hemogram, that is the platelet section, which I will call the thrombogram for the purposes of this presentation. This part, as the name suggests, looks into the coagulation aspect, that is based on the platelet count, and platelets are also called thrombocytes. They're usually useful at injury sites to prevent excessive bleeding by forming a clot in those areas. The normal range is usually between 150,000 to 450,000 cells per microliter of blood. A higher count is called thrombocytosis, while a lower count is called thrombocytopenia. So this part is very simple. It's just about thrombocytosis and thrombocytopenia. So the most common clinical picture I have personally come across is thrombocytopenia, and is usually manifested in these conditions. If you have a very low platelet count in a patient, then you must start suspecting these conditions. One is bleeding leading to loss of platelets. Maybe the patient has had excessive hemorrhage and has lost a lot of whole blood, which part of it is the platelets. So platelet loss due to excessive bleeding could lead to thrombocytopenia. Aplastic anemia, bone marrow insufficiency. Most patients I met were usually having these as well. So the low platelet count, especially for younger patients, is always associated with something to do with the bone marrow. So if you see that, ensure, and especially if it's consistent, you treat, it comes back, then ensure this patient does bone marrow aspiration and that sample is histologically analyzed for the bone marrow functions to be assessed properly. It could also be because of infections, and then drugs like cytotoxic agents like anti-epileptic drugs, valproate, valproic acid, carbamazepine, phenytoin, phenobarbital. All these cause thrombocytopenia. The other cause, of course, is infections. We have talked about that, and DIC, that is disseminated intravascular coagulopathy. Check for this, especially in pregnant women. When we have high infections, when we have high WBCs and low platelet count, highly likely we could be having a DIC situation. HIV and AIDS is also another cause. And then immune thrombocytopenic purpura, we talked about this, but you can go and look into this. I have come across a patient with HIV and AIDS, and in HIV and AIDS you could easily have ITP. ITP is the immune thrombocytopenic purpura, and this patient had a lot of published scars on the skin. We did a lot of dermatological consult, yet it was an immune reaction. So you can always pick this, especially if it's only the platelets that are affected, the patient is immunocompromised, and you can see that purpura is usually purplish in color, and it is associated with this. So it's an immune reaction that can be stopped by using steroids like prednisolone, high dose for around 14 weeks to 1 month. This patient will be able to get to a better level. Of course, pregnancy, we have the HELP syndrome. You know that. We discussed that in obstetrics and gynecology. That is hemolysis, elevated liver enzymes, and low platelet count. So this can also lead to thrombocytopenia. Heparin-induced thrombocytopenia, that is a long-term use of anticoagulants, can cause thrombocytopenia. Microangiopathic hemolytic anemia, you can also go and check this condition. All these are causes of low platelet count. Of course, high platelet count is called thrombocytosis, and it's common in infections, inflammatory reactions, myeloproliferative disorders, malignancies, hyposplenism. Of course, when the spleen is not there, the spleen functions to destroy the blood cells. If it's not there, it means that platelet destruction will be interfered with. So hyposplenism leads to high platelet count, and that could lead to thrombocytosis. I think we have done the basic aspects of the full hemogram. From there, I just want us to go through samples now, just some examples of full hemograms, and try to look at what we have been talking about. So I'll start with this one. This is a full hemogram. I'll not go into the biodata. If you're a student and with us here, ensure you always start the right way. You have to start with the patient's name. You have to identify the date on which this test was done. Do all the necessary preliminaries. Start with the biodata, identify the date, and then start with the ranges. So let's start with the ranges. I have a way of approaching this that I would like us to look into. Oh, sorry, I didn't teach you how to read this white blood cell section properly. First of all, you need to look at all the cells. WBCs elevated, yes. RBCs elevated, no. Platelets elevated, no. The upper limit is at 450. So if all of them are elevated, that is usually called pancytosis. The picture is pancytosis if all of them are elevated. If all of them are low, then that is pancytopenia. If two are elevated, bicytosis. If two are low, then bicytopenia. If one is elevated, white blood cell is called leukocytosis. Erythrocytes, erythrocytosis, and of course thrombocytes, thrombocytosis. If they are low again, thrombocytes, thrombocytopenia, erythrocytes, erythrocytopenia, and WBCs, leukocytopenia. So let's look at these white blood cells systematically. We said number one, you look at the range, and the range is high in the white blood cells. So that signals an inflammatory action. Two, you look at the trend. We don't have the trend, but if this full hem is a second one, and the other one had been taken and was at 26, then we can say it's getting better. And also, if it had been, the first one had been taken and it was at 12 and something was done, then we can say it's worsening the situation. So that is the second thing. You have to look at the trend. We cannot look at the trend here. The third thing we have to look at is the differential. So the differentials here, we said white blood cells are of two types, and that is we have to look at the granulocytes, number one, which are made of three: Ben, that is basophils, eosinophils, and neutrophils. Of course, the basophils, we cannot see the differentials here from this picture, but with granulocytes being high, we said neutrophils occupy around 40 to 70% of total white blood cell count, so we expect that neutrophils could be high here, eosinophils could be high as well, and basophils could be high. So if you're managing this patient and you don't have those differentials, you have to capture those in mind, that this patient could be having both an infective inflammatory process and an allergic inflammatory process. You have to check on that. And then of course the lymphocytes here are low. We said a low lymphocyte count signals a probable viral infection, HIV, AIDS, autoimmune disease. You need to screen them for you to be sure why is the lymphocyte count low. So again, we do not have the monocytes in this picture. That is really not helpful for us now, but at least you have that picture that there is an infective process. There is leukocytosis marked with granulocytosis, query neutrophilia, query eosinophilia, query basophilia, and then manage that patient appropriately. This at least will guide your further diagnostic tests that you can order on this patient. So the other thing you have to look in this patient is the steroidal action. Ask this patient if he has been using steroids. But one thing about the picture of a full hemogram that is marked with steroidal use is all of these things are usually elevated. You know why WBCs are elevated in patients who use steroids? It's because of two main things. First is, I think, demagination. Demagination, the way steroids work, they try to suppress the immune action. So what happens is they take them away from the periphery. Most of the white blood cells usually rush to the periphery to try and respond to injuries and the inflammatory actions in the periphery of the blood vessel. But when you use steroids continuously, it drags these white blood cells towards the center. That's what we call demagination. It brings them towards the center. So if we draw blood, which you usually draw from the center of a blood vessel, you are likely going to pick a lot of white blood cells, and that is what causes that elevation in patients who use steroids for a longer durations of time. So it could be elevated because of steroids. Ask that patient. That should be relevant from your history. And if you have had that history of steroids that is at 60% caused by demagination, then you could know why the WBCs are high. The other thing you need to know is query any form of malignancies and chronic illnesses. Like here, you would query things like HIV, query any malignancies, because query also any autoimmune diseases that are known to the patient, because that picture is relevant in this. The other part of this that I would like us to look at is the RBCs. RBCs, look at this picture. Normal HB, normal RBC count, but a low hematocrit count, which means the amount of red blood cells in whole blood is low. Low MCV, which means the size of those red blood cells are also low. And then low MCH, which means the hemoglobin concentration again in those small blood cells is low. That hemoglobin concentration in those small blood cells is low. So that tells you there is some hypoperfusion, kind of hypoperfusion that is going on. And if this is not corrected, could be because of the infectious process as well. If it's not corrected, it could soon affect the HB and the total RBC count. Another thing that is important here is the RD, the red cell distribution width. We say that if it's high, it signals malabsorption. There has been a long-term problem in absorbing the nutrients, the iron. So there is both iron deficiency, there is both folate and vitamin B12 deficiency, because those that are responsible for macrocytic anemia are not being absorbed. Those are responsible for micro are also not being absorbed. So we have both microcytic and macrocytic cells. This tells us that this patient could be having a GI issue as well, and the gut is not having proper absorption. This could have been causing this kind of problem we are seeing in blood. So again, that will guide your further diagnostic tests while handling such kind of patient. I don't know what else you're seeing. I don't want to comment on these platelets because I think 429 is still within normal range. We count it from 150 to 450, and 429 I think is still within normal range for me. I don't know why this machine tried to capture it there as high. So I think that is just a general guide. You can go through many other full hemograms and try to look at them to ensure that you acquaint yourself with these things. That's all in my CME today. Let me just go through some few questions with you guys so that we try to remind ourselves if we have any, we have grasped any. Which of the following is not a cause of erythrocytosis? Erythrocytosis is, of course, high red blood cell count. Which is not a cause of high red blood cell count? A, smoking. Yes, that's a cause because that compensatory reaction to try and cover for that lack of oxygen will cause a high number of red blood cells. Polycythemia vera. Yes, we talked about that. Apoproducing tumor. These are no. Apoproducing tumor. Yes, because the bone marrow will produce a lot of red blood cells, and that will cause erythrocytosis. Alcohol, no. So I would go for alcohol here. I don't know what you would go for. The other question here, which of the following is a cause of thrombocytopenia? That is low platelet count. Heparin, of course, yes, that's very simple. Splenectomy, we talked about it. Splenectomy causes high. Bacterial causes high as well. Burns, high, of course, to try and prevent bleeding. You know that. What is thrombocytosis? Surely, what is thrombocytosis? Give me an answer in the comment section. Are reticulocytes increased or decreased in the presence of hemolysis? We talked about this. If there is hemolysis, reticulocytes will go high to try and compensate for blood being lost. So they'll increase in a full hemogram with of a patient with hemolytic aspects of blood going on. And then, which of the following does not typically produce a microcytic hyperchromic anemia? Microcytic, that means big cells. Which one does not produce? Answer me this in the comment section. But of course, A, produces. We talked about that. Just answer me this in the comment section. The last one, you can go through these questions in the slides. I'm going to attach them in the description of this video, and my article, I've written an article on this as well. You can check it in the description of this video, and follow me on LinkedIn to try and read it wholesomely. Which of the following is not a cause of increased neutrophilia? A, bacterial infection causes. Lymphoma, corticosteroids causes. Good. Which one is not? I think I would go for lymphoma. Lymphoma is a cancer of the lymphoid glands. Chronic myeloid leukemia, at least this one has something to do with the bone marrow. Anything that has something to do with the bone marrow will primarily increase the cells. But something that is away from the bone marrow may increase the neutrophils secondarily, not primarily. So it is far from being closer to how these others increase the number of neutrophils. So I think I would go for lymphoma here. I don't know what you would go for. Yeah, so many of these I don't want to go through. Let me just go to them. Your patient, 34-year-old, presents with fatigue, lethargy. You note the following in a blood count: hemoglobin, HB, that is 92, that's 9, and then red cell count is very low at 2.3. What do you think? Which of the following indices will provide the most information? Surely, I don't. This MCV is MCV will help you more than hematocrit here, because it will tell you the size of the red blood cells. So MCV here, I think. Yeah, you can go through these questions, download in my PPT there. Thank you for being with me. Remember to subscribe to our pages here at Medifield Healthcare, and follow us on social media to support this initiative. Also, remember to follow me on LinkedIn through that link where I've written that article on comprehensive analysis of a full hemogram. My name is Regan Mondi. It was nice having you. Thank you, and see you again.